Okay, so let's move on to asthma, which tends to be a chronic disorder, but it's intermittent. Okay, so and it's reversible, meaning patients are going to have intermittent symptoms, and it's going to return back to being asymptomatic. Okay, so it's reversible bronchoconstriction. Okay, and inflammation of the airways. So there's two components to asthma, the bronchoconstriction and the inflammation of the bronchial tubes. Okay, and so if you remember that, you're going to remember all the treatments because they're going to address one of those two things, bronchoconstriction, airway inflammation. Okay, so a patient with asthma can be going along just fine with no symptoms at all and then have an asthma flare up. And then once it's treated and they get through it, they go back to breathing normally again. Okay, so it's intermittent and reversible. Okay. So asthma is can be referred to as basically twitchy airways. So patients are responding to something in the environment. So we would call that extrinsic asthma. So they're inhaling something that's just irritating their airways. And what are the airways doing? They're bronchoconstricting and becoming inflamed. Excuse me. Um, Intrinsic asthma just means there's nothing that someone's breathing in that's doing it. They're just getting flare-ups of asthma. Okay, so I wouldn't hold those terms too tightly, but I'm just telling you that some people are sensitive to extrinsic conditions in the environment, and some people just have intrinsic asthma where they just get recurrent episodes of bronchoconstriction and airway inflammation. So this image is just showing you the airway inflammation, okay, and bronchoconstriction. So on the left is a normal airway. The middle one is showing you some bronchoconstriction, okay? And you're not going to breathe very well through a very narrow tube. It's going to make ventilation more difficult. So it's going to feel like breathing through a straw, okay? And then on top of that, airway inflammation, okay? So, and when you have airway inflammation, you get more mucus production into the airways, and that's going to cause even more narrowing of the airway temporarily. Okay, so what kind of symptoms? Dyspnea, for sure, shortness of breath, right? The airways are irritated, coughing, wheezing, especially expiratory wheezing. If someone has inspiratory wheezing, that's a bad sign. That usually means that the airway is super narrowed. Okay, so expiratory wheezing is very common. Inspiratory wheezing, much more of a late finding, more serious. Mucus production in asthma, yeah, we just mentioned that there's a lot of inflammation. As the asthma gets worse, could you be using your accessory muscles in your neck? Yes, right? Because the body's saying, okay, I have to open up this chest and I have to push out the air during exhalation. So I'm going to use more muscles. Prolonged exhalation, yeah, because of all the mucus and bronchoconstriction, you can't get all the air out. So we usually think of asthma as a condition of difficulty exhaling the air. Okay, it can get to the point of difficulty inhaling the air, but typically patients have come looking for help during the expiratory wheezing phase. Okay, poor oxygenation, yeah, because they're having difficulty ventilating. They're having difficulty getting the air to the alveoli. So as it gets worse and worse and worse, they're going to have hypoxemia, right, and low O2 sats. Increased chest diameter, they can have that during a flare-up. Why? Well, they breathe in air, they can't get it out. They breathe in air, they can't get it out. So they're breathing at higher lung volumes because, as I mentioned, asthma is a difficulty with getting the air out usually. Okay, so what about an exacerbation of asthma? So patients going along fine, They're taking their fluticasone inhaler regularly to prevent asthma exacerbations, and then they get, say, a cold, and then the cold settles in their chest, and they get an asthma flare-up. So they begin with shortness of breath and wheezing. What are precipitating factors? Well, it could be something in the environment. It could be a viral infection that started with a cough and then that triggered their asthma. So remember, asthma is like twitchy airways. So anything that irritates the airways may put them into an asthma exacerbation. Okay. What else would you ask about in terms of an exacerbation? So you want to know about the onset. Anything that precipitated it. Are you visiting someone's cottage? Are you living in a basement? Are you smoking? Anything like that. What medications the patient's on? What inhalers? Are you on a short-acting beta agonist? Do you take a inhaled corticosteroid? Things like that. Methods to relieve the asthma. Do you use your short-acting beta agonist? How frequently do you use it? We often don't like to hear that someone's using their albuterol frequently. That means their asthma is not under good control, and we may need to adjust one of their long-term control medications, such as fluticasone, okay, or maybe a long-acting beta agonist, such as salmeterol. Okay, so asthma diagnostic. So how do we diagnose someone with asthma or an asthma flare-up? So really it's by history first, right? So someone comes in and says, every once in a while I'm short of breath and wheezing, and then it settles, and then it comes back when I get a cold that I start to get short of breath and wheezing again. So it's intermittent and recurrent, right? So if someone comes in shortness of breath with wheezing, what kind of tests might we use to diagnose asthma and to see the severity of the asthma? So we can use labs if someone comes in short of breath and wheezing to see the severity of the asthma. It's not going to diagnose the asthma. So they might be hypoxemic on an arterial blood gas. Initially, because an asthmatic is breathing fast, right? Breathing fast to try and maintain that oxygen going into the lungs, but they're blowing off the CO2 faster. So initially, we'll often see patients with a low CO2 because of the fast respirations. They're able to blow off the CO2. Okay, so as the asthma gets worse and the bronchial tubes get tighter and tighter and more inflamed, well, now they're going to start getting tired, right? It's getting harder and harder to breathe, and they're not able to breathe at those fast rates for very long. So they're going to start to get an elevation in CO2. That's a bad sign. So if we see an asthmatic that has increased CO2 in the blood, we start to think that this person is tiring out and they may need to be intubated. We much prefer to see a low CO2 just because they're breathing fast. Okay. Sputum cultures are going to be negative in asthma if it's just asthma because there's no infection as part of asthma. Procedures. So pulmonary function tests are usually done when the patient has recovered from their asthma flare-up. So we send them to a lab to have pulmonary function tests, and that can really help us diagnose asthma. So they're going to have difficulty getting the air out, and that's going to be picked up on a pulmonary function test. Okay. So pulmonary function test is one of the primary ways that we're going to diagnose asthma. So when we tell them to breathe out their vital capacity, they have difficulty getting out all of the oxygen. All of the air. Okay, because they have airway narrowing. Okay, a chest X-ray is going to be typically normal in asthma. We will sometimes get a chest X-ray just to make sure that it's nothing else that has brought them in with shortness of breath and hypoxemia. But if it's just asthma, we don't see much on the chest X-ray because it's not a lung problem. It's a bronchial constriction and airway inflammation problem. So we don't see it on chest X-ray. Okay, so let's just talk about a couple of interventions. So if someone comes in with mild to moderate asthma, okay, we're going to put them on a bed and we're going to um, check their vital signs, check their oxygen saturation, and then we can just provide them with, say, a nebulized treatment of albuterol. Okay, and typically those patients get better once we bronchodilate their lungs, and then we talk to them about taking regular albuterol at home. We might start a fluticasone inhaler. If they're not on a fluticasone inhaler, we can start it. If they are on one, we'll often introduce oral prednisone to settle down the inflammation. Okay. So what about someone who comes in sicker with asthma? So they have more bronchoconstriction and more airway inflammation. Well, we keep them upright in bed because that's going to help them breathe better. These patients would never want to be laid down in bed. Okay, they're much too short of breath. Often they're anxious and nervous about the condition that they can't get air into their lungs, so they're anxious. We put them on a cardiac monitor. We put them on continuous oxygen saturation monitor. And we're going to get frequent vital signs. Okay. We definitely try to calm down the patient and talk to them slowly and explain what we're going to do because they're often anxious about not getting oxygen into their lungs. Any of us would be, right? So administration of the medications, we'll talk about the medications. We've already spoken about them. Which ones do we use? Well, beta-2 agonists, albuterol, right? If they're really short of breath, we can put beta-2 agonists such as albuterol into a nebulizer. We can add some ipratropium, that anticholinergic drug, which also comes as an inhaler, but it comes as a liquid that we can use in a nebulizer to bronchodilate. Okay. We can use theophylline. I'm going to tell you I haven't used theophylline in over 25 years. Well, 20 years. Because it just has so many side effects and it's not overly effective. Okay. That doesn't mean that you don't need to know a bit about it, but it just means it's just not used very often anymore. Okay. We're typically going to start glucocorticoids, right? So if someone's really sick, we're going to give it to them IV, such as methylprednisolone. If they're moderately sick and they can take oral medications, we may start oral prednisone. So with albuterol, which is a beta-2 agonist, what are the adverse effects to watch for? Well, they're going to get tremulous. They often get tachycardic, and they get nauseated with it too. Okay. Ipratropium, the anticholinergic, dry mouth. In terms of theophylline, tachycardia, jitteriness. Just think of taking 6 cups of coffee. It's going to have a similar effect. Nausea, tachycardia, just agitation is going to happen with theophylline. Okay. Remember, salmeterol is a long-acting beta agonist. We don't use that to break an asthma attack. That's to prevent asthma attack. That's a long-term treatment. Okay. So, what else can we use? So, okay, could we use leukotriene antagonists to treat asthma? Sure, such as montelukast. We don't because they're not very effective. Mast cell stabilizers like cromolyn, sure, because there is an allergic component to asthma. We don't because they're not very effective. Monoclonal antibodies, that would be for long-term control of someone with severe asthma that we've tried everything else. Okay, so in terms of anti-inflammatories, we really go to the corticosteroids. Fluticasone in an inhaler form, prednisone in an oral form, methylprednisolone in an IV form. So let's just look at some common asthma medications again. And you can break it up into medications that patients are taking long term to control their asthma. So we'll call those long lasting medications, and medications that patients are taking in the short term to either because they have an asthma flare up or they are, say, visiting someone's cottage and that's what caused their asthma flare-up. Okay, so short-acting medications to break an asthma flare-up, and then long-term control medications. Okay, let's start with long-term control. So what kind of medication might someone be on a daily basis to prevent frequent asthma exacerbations? Well, definitely the inhaled corticosteroids, right? So fluticasone, which is Flovent, and there's a whole bunch of other ones. These are brand names, Pulmicort and Qvar, but they're all the same. They're all inhaled corticosteroids. There's really not one better than another. Okay, they're all effective if they're taken regularly. Remember, they're not used to treat an acute flare-up. Okay, they're for long-term control. Some people might need to be on systemic corticosteroids longer term. That's the rarity. Most people don't need to take prednisone long term, luckily, because of all the adverse effects that would cause, right? Just think of being on prednisone long term. Peptic ulcers, thin skin, diabetes, cataracts, hypertension, fluid retention with peripheral edema, thin skin with bruising, moon face, all those Cushing symptoms, weight gain, increased appetite, insomnia. That's all from glucocorticoids. Okay? Luckily, most patients don't need to remain on prednisone. Long-acting beta-2 agonists that you would take twice a day to keep the tubes open, yes, such as salmeterol, okay? Or combined medications. So Advair is just a combination medication of a long-acting beta agonist and a inhaled glucocorticoid. Remember, there's two parts of treating asthma, right? There's the bronchoconstriction and the airway inflammation. So it's always going to be, treatment's always going to be aimed at one of those. Okay, so when I mentioned Advair, well, that's fluticasone and salmeterol. Okay, so you're just addressing the two parts of the condition long term. Leukotriene modifiers. We thought these would be great because they block some of the inflammation. So Singulair is one of them. Not very effective. We often don't use them. Okay. Mast cell stabilizers, I think they're basically disappearing from the market, but cromolyn would be a mast cell stabilizer. Again, we thought it would reduce allergies and inflammation, and that's why they were used. Okay. And lastly, monoclonal antibodies. Again, that's for really severe asthma. That would not be for your average person with asthma. Okay. Short-acting medications. So if someone comes in and they have a flare-up of their asthma, so they were going along just fine, they were taking their fluticasone inhaler, and they got a cold. And the cold triggered their really twitchy airways to bronchoconstrict and increase inflammation. What can we use? Well, short-acting beta agonists, those are the rescue medications, right? Albuterol. Those are the side effects, the increased heart rate, the shaking, the nausea, tremors. But this is what we give in the emergency room. So albuterol, and often we'll combine Atrovent, which is ipratropium, in the same nebulizer. We'll just give it to them as a nebulizer to bronchodilate. Okay, so that's one arm of the treatment, the bronchodilation. What's the other arm? To decrease inflammation. What do we use for that? Corticosteroids. So if it's really, really mild asthma, okay, we'll give them inhaled corticosteroids such as fluticasone. If it's anything else, moderate, severe asthma, they're either going to get oral prednisone or IV methylprednisolone. Just depends on whether they're going home or they're staying in hospital. Okay, and of course, remember all the side effects of the cortisones. Really important. Okay, so what about complications of asthma? Okay, let's just talk about the first one. So someone who's asthmatic and they come in really short of breath, they're sweaty, they're pale, they're fearful, their eyes are dilated, they know they're in trouble, right? Well, they could run into respiratory failure. Their airways are so narrowed that they just can't get the air to the alveoli. They're having difficulty breathing in air and in particular exhaling air, and they go into respiratory failure. Well, those patients usually need intubating and mechanical ventilation. Okay, that's really severe asthma, and intubating an asthma is not taken lightly, because you can imagine trying to push air through a mechanical ventilator with really narrowed airways. Even the ventilator has trouble pushing the air through the narrowed airways. Okay. Status asthmaticus is another one, and this is someone that we just can't break the bronchoconstriction and all the inflammation in the lungs, in the bronchial tubes, with the medications such as albuterol, ipratropium, and oral or IV corticosteroids. So they just continue to wheeze, increased work of breath, using their accessory muscles, and we can't break the cycle. And they usually need intubation as well, right? And on top of that, they're going to need oxygen therapy. They're going to get bronchodilators through the endotracheal tube, or through the ventilator. We can mist in bronchodilators. We can use epinephrine, which is a very strong beta and alpha agonist. So that's going to help bronchodilate. Okay. And of course, we start IV steroids. Okay. I wasn't looking at the slide here while I was talking, but let me look at it. So expected findings. Well, expected findings of status asthmaticus is someone who's gasping for air. They're breathing fast, they look desperate, they're anxious, sweaty, and pale. Okay? In fact, when their wheezing disappears, when we hear a silent chest in a patient with status asthmaticus, that's a really bad sign. If we don't hear any wheezing on exhalation or inspiration, and we hear basically a silent chest, that means they're going to go into respiratory failure. Okay. Status asthmaticus, initially they might be in respiratory alkalosis just because they're breathing fast. Okay, they're breathing fast, they're blowing the CO2 out. Okay, so when you blow your CO2 out, your pH is going to go up because you're breathing so fast to try and maintain oxygenation, you're actually breathing out your CO2. But then they start to fail. They start to fatigue and fail, and they retain their CO2, and then it becomes respiratory acidosis. Okay? So what do? Continuous albuterol nebulizers, one after the next, Okay, we'll try that to try and break it, the status asthmaticus. We'll add ipratropium to the albuterol. We will give them IV magnesium. So magnesium is a smooth muscle relaxant. So it relaxes the smooth muscle, trying to bronchodilate those tubes. We'll give them IV epinephrine to bronchodilate the tubes. So we're basically throwing everything at them. We'll give them IV methylprednisolone to try and reduce the inflammation, but all the while preparing for intubation if all of these things are failing. Okay, so we're basically throwing the kitchen sink of medications at someone with status asthmaticus. Okay, so oxygen, bronchodilators such as albuterol and ipratropium, IV epinephrine, IV steroids, and then unfortunately some patients still need to be intubated. Okay, so definitely anyone who's asthmatic, it's a bad idea to smoke. It's a bad idea to smoke in general, but definitely if you're asthmatic because you're inhaling toxins, which are going to trigger the asthma, right? So advice on quitting smoking is really important. Avoiding triggers. So some patients know what will trigger their asthma, whether it's a viral infection, which is hard to avoid, or it's going into someone's basement or visiting a cottage that's moldy and dusty, or it's seasonal allergies, or chemicals at work. They usually know that there's certain things that trigger their asthma. Okay. Administering inhalers. So we often advise use of an aerochamber or a spacer, another term for it, while using metered dose inhalers. Right? Now, some medications also come in a dry powder form, so you don't need the aerochamber. Okay? So aerochamber just makes it easier to get the medication lower into the lungs where it needs to be. Okay? So often they just need advice on how to take the inhaler, right? Shaking it well first, putting it to the aerochamber, administering the proper metered dose inhalers, and then taking 2-3 deep breaths to hold the medication in the lung. Okay? The importance of keeping to the medication. So the long-term medication needs to be taken regularly every day. You need to take your long-acting beta agonist if you're on one. Definitely your daily inhaled corticosteroid is critical to preventing asthma flare-ups. Okay? And remember that asthma often lives with other conditions. So patients often will describe, I have allergic rhinitis, so I've got an itchy nose, I'm sneezing a lot. So they're kind of sensitive to a lot of things. It's not just asthma by itself. I have eczema, which is atopic dermatitis. So I have itchy, dry skin that cracks open sometimes. Oh, and on top of that, I have wheezing and shortness of breath. So all of these kind of live together. Okay. And often we'll hear of, when we're asking about family history, that there might be a sister or brother that has asthma, or there might be a sister or brother that has eczema or allergic rhinitis. So asthma runs through families, but the other conditions that are associated with asthma, eczema and allergic rhinitis, or other allergic type symptoms, often run through the whole family as well. Okay, so someone might say, well, I have seasonal allergies, and my brother has asthma, and my sister has eczema. Okay, they all tend to run together. Okay, so let's do the questions at the end of the chapter. Number one, a nurse in the emergency department is caring for a client who is experiencing an acute asthma attack. Which of the following assessments indicate that the respiratory status is declining? Well, I don't really like this question because declining from what? From normal? So let's just assume it's declining from normal. A O2 sat of 95%, well, that's normal, so that's okay. 95 to 100% is normal. Wheezing isn't normal, so we'll include that because you shouldn't usually wheeze, and that can be an indication of asthma. Retraction of sternal muscles. So if you're using accessory muscles, say in your neck, that's an indication that you're working harder to breathe, and that can happen in asthma. Pink mucous membranes is normal, right? Your The mucous membranes are usually pink, so that's not concerning. If they were bluish or cyanotic, that would be concerning. Tachycardia. Well, as the asthma gets worse, or you're taking lots of albuterol, you're going to be tachycardic. So if you're getting more short of breath, your body is sensing that you're having to breathe faster to get oxygen into your blood. And on top of that, the body's increasing heart rate to deliver more blood to the lungs and to the body. So tachycardia would be an answer. So B, C, and E. A nurse, number 2 is a nurse is caring for a client 2 hours after admission. The client has an O2 sat of 91%, that's on the low side, exhibits audible wheezes, and is using accessory muscles when breathing. Which of the following classes of medications should the nurse expect to administer? So this is someone who has a low O2 sat, wheezing, and is using accessory muscle use, so they're working a bit hard to breathe. So an antibiotic, no, that's not going to rescue them. A beta blocker, I hope not. That's for blood pressure. An antiviral, no, there's no indication of needing a treatment with an antiviral. Beta 2 agonist, bronchodilate those bronchial tubes. Get the person breathing better, right? Their O2 sat will go up. They won't need to use their accessory muscles, and the wheezing will resolve. Okay. Number 3, a nurse is providing discharge teaching to a client who has a new prescription for prednisone for asthma. Which of the following statements indicates understanding? I will decrease my fluid intake while taking this medication. I don't think you need to decrease your fluid intake. I mean, one of the effects of prednisone is you're going to retain fluid and have a bit of peripheral edema, but I don't think you need to decrease your fluids while taking this medication. I will expect to have black tarry stools. While you shouldn't expect to have black tarry stools, you may get them if you develop a bleeding ulcer, because those are symptoms of or signs of melena. I will take my medication with meals, absolutely. Glucocorticoids such as prednisone are hard on the stomach. They can cause gastritis and peptic ulcers. I will monitor for weight loss while on this medication. No, you will likely gain a bit of weight if you're on this medication for weeks or months. Okay, so it would be weight gain. So the answer is C. 4, a nurse is assessing a client who has a history of asthma. Which of the following factors should the nurse identify as a risk factor for asthma? Sex, environmental allergies, absolutely. Alcohol use, not usually. History of diabetes, not usually. So environmental allergies would be a risk factor because remember I mentioned asthma often lives with hay fever and allergic rhinitis. So the answer would be B. Okay, last question. A nurse is reinforcing teaching with a client on the purpose of taking a bronchodilator. Which of the following client statements indicates understanding? This medication can decrease my immune system. No, corticosteroids can, but bronchodilators such as albuterol and ipratropium don't. I take this medication to prevent asthma attacks. I mean, that's not really a fair question. Are you taking it to prevent? Well, you might be taking it to treat an acute attack if it's a short-acting beta agonist. If it's a long-acting beta agonist, then you would take it to prevent asthma attacks. So let's come back to the answer. I need to take this medication with food. No, you don't usually need to take a bronchodilator with food. They're usually inhaled or nebulized, so you wouldn't need to take it with food. This medication has a slow onset to treat my symptoms. No, beta agonists, I don't like this question because it doesn't actually tell you which bronchodilator we're talking about here. So we need to make assumptions. The medication has a slow onset. No, beta agonists can have a rapid onset. So, I mean, I guess the best answer here is B. I take this medication to prevent asthma attacks, since salmeterol is a long-acting beta agonist that's a bronchodilator, or ipratropium, and salbuterol is a short-acting one to treat acute attacks. I'm not a big fan of this question.